Hi, everyone. Good evening. Welcome to Ask the Expert, presented by Mary Washington Healthcare. Tonight's session is the third of a four-part series featuring heart care professionals from Mary Washington Cardiology. During this session, our experts will discuss heart failure, atrial fibrillation, coronary artery disease, preventative cardiology, and postural tachycardia syndrome, or POTS. This program is called Ask the Expert, so of course we will answer your questions live. Our providers want to hear from you. To submit a question for our panel, just drop it in the chat here on Facebook. Today's panelists have a wealth of experience in cardiology, and they are truly experts in their field. Let's meet them. First, we have Dr. Aaron Schatz, Service Line Medical Director of Cardiology at Mary Washington Hospital. He is a cardiovascular disease specialist skilled in the discipline of treating heart failure, heart attacks, high cholesterol, high blood pressure, and valvular heart disease. He is a fellow of the American College of Cardiology and carries boards in internal medicine, cardiology, echocardiography, nuclear cardiology, and cardiac CT. Next, we have Dr. Pim Lorvadaya, a cardiology and electrophysiology specialist. Dr. Lorvadaya treats all types of atrial and ventricular arrhythmias. He performs multiple types of ablations, implants devices like pacemakers and defibrillators, and reads all types of cardiac monitors, ECGs, and implant loop recorders. He also treats POTS. Finally, we have board-certified family nurse practitioner Ariel Freeman. Ms. Freeman has been a cardiology nurse practitioner for 9 years, managing comprehensive cardiac care and promoting health and wellness. She has experience as a critical care nurse in the US Navy and later as a flight nurse in the US Air Force. Welcome, everyone, and thanks for joining us tonight. So we're going to start the program tonight by answering a few commonly asked questions that our providers often hear in their practice. So Dr. Schatz, we'll start with you. Can you share with our community some of the different types of heart failure and how you treat them?
Yes, thank you, Emily. So there's really two main types of heart failure. There's a type of heart failure where your heart is weaker and it doesn't pump as well, and that's called systolic heart failure. And then there's another term called diastolic heart failure. So that is really when your heart is too stiff and doesn't fill well. The therapies for those are pretty different. There's some overlap in medical therapy. But essentially what we do is we have some guideline directed medical therapies that we initiate based off of how your heart's squeezing and other comorbidities that you have. And we follow you with serial echocardiograms to see your response to medications and see if you're eligible for any devices or therapies outside of medications.
Great, thanks, Dr. Schatz. Ariel, I imagine you probably see a lot of heart failure patients in your practice. Do you have anything to add to Dr. Schatz's comments?
Well, I would say, every person that we see with heart failure, that we have, these two kind of distinctive categories for heart failure, everyone's still a little bit different. And so we have a guideline approach, best medicine, pillars of care that we think about for everyone, but still everyone's a little bit different. So, I think it's really important that we tailor, what therapy, as best we can to each person. So that's really what I have.
Great, thanks, Ariel. So it sounds like we treat each person, each patient as an individual and not a number. We're looking at them and their personal needs.
Yes, Emily.
Thank you. Dr. Lorvadaya, there are a lot of reasons why somebody might come to a cardiac specialist. They're looking for somebody to fix their heart. So can you talk to us a little bit about some of the procedures or surgeries that someone might need to start feeling better in terms of their heart care?
Yes. So when it comes to procedure, so largely the procedure list in cardiology are kind of from two sides. One is, what I usually call the plumbing side. So the coronary arteries, if they have blockages, We typically would, go in and look at the blockage, and if it's significant, then we put in stents. So that's, the job for, the interventionalists or the so-called plumbers for the heart. And then on my side, I'm the electrician for the heart, or the electrical specialist. So I deal with different types of, heart rhythm issues. Some are related to slow heart rhythm, so we would put in pacemakers. Some could be related to weakening the heart muscle, and then we would put in things like defibrillators. Um, on the other side are electrical issues related to the heart rhythm being too fast, but too fast in an abnormal way, not fast because you're running a marathon, but fast because you have a short circuit somewhere in the heart. So we would do an ablation where we would pass catheters up into the heart, and then we would induce the heart to go into the arrhythmia that we're looking for, and then we would find the short circuit and then ablate it, which is basically get rid of the short circuits.
Very good. Thank you. That's a great way of thinking about it, as our bodies as structures with plumbing and electricity.
Yes.
Ariel, you've been a family nurse practitioner for quite some time. So you've seen a lot of patients, probably, during their regular care and, leading up to needing a cardiologist versus people who should have seen a cardiologist a long time ago. So when is a good time for someone to see a cardiologist?
Well, I would say we start with most people when they are starting out with a cardiologist, it's for evaluation of a certain symptom. And so, there's certain constellation of symptoms that we routinely evaluate. Chest pain, of course, is one of them, shortness of breath, um, palpitations, dizziness, passing out, fluid retention, swelling in the legs. Those are all kind of the typical things that symptoms that we usually see. Other times, we see patients for a finding of a new murmur. So they see their primary care doctor and they have a new murmur, or they're on multiple blood pressure medications and still not getting good blood pressure control. And then sometimes people come in just because they want to look at their risk. So they have maybe a strong family history, heart disease, and they want to, maybe they have some concerns about their personal risk. And so we'll do, if they're coming in with no symptoms, or even if they have symptoms, we're kind of looking at everything. We're looking at, the immediate, what's the symptom that you're coming in with, and then looking at kind of everything else and what are you at risk for, and how can we manage that best. I would say the best time to see the cardiologist is sooner versus later, because the goal is always prevention and catch things early when you can treat them. So early is best. And sometimes
Great.
I should just add on to that. Sometimes the symptoms are a little more subtle. So, there's a lot of reasons you can have palpitations or shortness of breath, and we're specifically looking for heart-related reasons. So a lot of times people have seen a lot of other specialists first, and then they come to us. So good question.
Awesome. That's great, Ariel. Thanks for sharing that information with our community. We've already got a couple of really good questions out in our live audience, folks who sound like they know what they're talking about. So Dr. Schatz, there's a question out here for you that relates back to your initial comments around systolic and diastolic heart failure. So someone in our audience is wondering if these things are the same as heart block, or if heart block is a synchronization issue. Can you speak to that a little further?
Absolutely. It's a really good question. And I think what it does is it supports the complexity within cardiology and cardiac disease processes. So people with heart failure can have heart block. Heart block itself is actually a Dr. Lorvidaya issue. And by that, I mean, he can fix that. Heart block essentially is when certain parts of the heart do not communicate well with the other parts of the heart electrically. So the top chambers of the heart, also known as the atria, may send a signal to the ventricles, or the bottom chamber of the heart, that is not always received. So people may have bradycardia and feel fatigue and other symptoms because of their heart block. Um, Heart block can lead to symptoms that overlap with heart failure, but they're usually two different entities.
Great. Thanks, Dr. Schatz. Dr. Lorvadaya, is there anything that you wanted to add to this question?
Yes. So, like Dr. Schatz said, heart block is, basically, even though it has the word block, and it often confuses people into thinking that they have a blockage, somewhere. In this situation, we are referring to the electrical signals that are, basically being inhibited in traveling to a different, chamber. There are different degrees of heart block. So some of them are fairly benign, and some of them are, malignant in the sense that, they need a pacemaker, urgently, or, sooner rather than later.
Thank you. And Dr. Lorvadaya, we have another question out here in the chat that I think is meant for you, and it's asking about ablations. And the question specifically asks if ablation helps with frequent PACS. Is that something that you can speak to?
Yes. So ablation can be helpful for frequent PACs or premature atrial contractions. Um, the 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 main limitation of ablation of that type is that often when we bring patients who have frequent PACs to the lab, and we are starting to do the procedure where we have to put them under sedation, a lot of times them being sleepy actually make the PACs disappear. So and if that's the case, then we are, quite limited in terms of how successful we'll be able to go after the PACs. But if they are having them frequently enough during the procedure, and provided that they're coming from one particular area or just, a couple of particular areas in the heart, then we typically can take care of them pretty successfully. There are situations where PACs are coming from multiple different locations of the heart. And in that situation, it would be exceedingly difficult to successfully get rid of them with the ablation.
Great, thank you. It sounds like we have some very educated people in cardiac issues watching tonight, which is very exciting. Ariel, we have a few people in the audience asking about diet and exercise and what roles that plays in cardiac health, and how much exercise they should be doing, what kind of foods they should be eating. Do you have some guidance that you give to your patients that you can share with our audience?
So I do, and I try to include that in almost every visit. I at least try to touch on that, a little bit, because, people come into cardiology and we prescribe medications and look at procedures and, do all of this. But really, patients have, they have some responsibility and in helping themselves feel better. And so, I think the general recommendation for exercise is, 30 minutes, 5 days a week of moderate intensity exercise. But when you say those numbers, it's not always meaningful, especially if people aren't doing anything or aren't able to do anything. They have limitations with arthritis or, or different reasons. And so I really try to have a conversation with that person and see where they are now. And then you try to set attainable goals. So if you're not doing anything, then 10 minutes a day of some activity, whatever that means, to help maintain their mobility and stamina, ultimately to be able to exercise. So it really just depends on that person. I again say, we say 30 minutes, but it doesn't have to be all at one time. It can be, in increments. And walking counts, being active in different ways count. And so, you try to make that goal attainable, at least for exercise. And again, focusing on maintaining mobility and just movement and whatever that means for you and working with your limitations. Does that answer the question?
Yeah, that's great, Ariel. Thank you so much.
And Emily, if I may add, I think this is why sorry to embarrass you, Ariel, that you're so good at what you do, because she's absolutely right. As she said earlier, guidelines are guidelines. They're written by the smartest people in the United States and then in Europe, in the world, on how we should be ideally managing patients with certain issues. But some is better than none. And for patients that come in and talk about exercise, if you're not doing anything's better than what you're doing. And the same people when it comes to diet. Well, if you're eating a whole pizza a day, a diet for that person may be a half a pizza a day. And you just have to work in realistic increments, because if you set your goals to an unattainable risk, or an unattainable level, then it's very unlikely that your patient or the physician, or APP will see results that are favorable, and that is discouraging.
Yeah, that's a great point, Dr. Schatz. The folks in my running group, especially the folks who are typically at the back, they even say, well, I might be going slow, but I'm still lapping people on the couch. Mm-hmm. So any bit is better than none. All right, we have quite a few questions out here in the audience around atrial fibrillation, or AFib. So Dr. Schatz, I'll start with you, and then Dr. Lorvadaya, I have some follow-up questions for you on AFib. So first, Dr. Schatz, what causes someone to develop AFib?
I think if I had the answer to that, I would be doing this conversation from some remote island that I would own. But it's multifactorial. We know that there are risk factors, and I think Dr. Lorvadaya is probably the expert in the room here that can speak most accurately and holistically to that. But we know that age is a risk factor. We know that prior atrial fibrillation is a risk factor. Certain things that we can alter and manage, like thyroid disease, hyperthyroidism, is a risk factor. Alcohol can increase really PACs and ectopy. So we do know that there are certain things in the lifestyle to adjust and not alter, but kind of try and control for. But ultimately, age is something that nobody can control for, and it is a disease process of the aging population.
Thanks, Dr. Schatz. So, Dr. Lorvadaya, let's turn over to you. Tell us what you know about AFib and how you treat AFib.
Yes. So as Dr. Schatz said, it's pretty much primarily a disease of aging. And the most common questions that I get when I first meet a patient who is diagnosed for the first time is, what could I have done to prevent it? In saying that they want to try to tell their kids, what to do to not, get it. And pretty much I say to them that the main thing is to not get old, because if you get old, then the AFib is gonna, increase, in risk. But others would be things like make sure that you know, check your blood pressure and control it as fast as possible. Eat healthy, exercise, things like that. As far as treatment, if someone has AFib, but the episodes are very, very few and far between, meaning, maybe one episode a year that's lasting, a couple minutes. At the beginning, we might more or less keep an eye on it, let it, get a little bit worse before we do anything about it. Most people that come to see us are usually in the later category, where they're having episodes that are more frequent, or even if they're not super frequent, they are very symptomatic. So then we would treat that with medications that can help control the rhythm, meaning that to prevent the AFib from happening to begin with, as well as in appropriate patients, placing them on blood thinners to make sure that they don't end up with a stroke. And then ultimately, if they are proven to be resistant to medications, or if they have a strong preference not to take medications for long term, then performing the ablation is also one of the very common pathway these days.
Thank you. We have another question that is specific to AFib that I think you can answer, Dr. Lorvidaya. So if someone has AFib and their heart monitor is reading less than 1%, is that somebody who can still have a long, healthy life while living with AFib?
So uh, the answer is that it depends if that less than 1% person is a relatively young and healthy person without many other medical problems, then yes, they could, lead a pretty healthy life for, quite some time. Although it doesn't necessarily mean that they shouldn't see someone on a regular basis for that. They should still follow up regularly with at least their primary care physician or ideally their cardiologist. On the other hand, if it's someone who has multiple medical other medical problems, have sleep apnea, they're obese, they have hypertension, they smoke, they have congestive heart failure, or they have coronary artery disease or diabetes, then those people are at a much higher risk of having stroke. So the treatment for those people would be quite different, and we tend to be quite a bit more aggressive in making sure that they're taking their blood thinners, and even depending on the duration of each of these episodes, even if they're all in all a small percentage, we might actually gear them toward taking something to prevent it from happening, or even the ablation on an earlier side.
Thank you. Dr. Schatz, we have a question out here in the audience about procedures that we are able to do at our main hospital, Mary Washington Hospital, to help folks with their cardiac conditions, whatever they may be. So, as the service line medical director for cardiology at Mary Washington Hospital, can you give us a little background on some of the procedures that we have available for people to keep their hearts healthy?
Absolutely, sure. It's a good question. So, Mary Washington is a unique hospital because of our location, being really an hour plus from major academic hospitals around us. So we know that, our service here is to our community and to the patients in the outlying areas around Fredericksburg. And our goal is to be able to provide the state of the art procedures that other academic institutions in the United States and the world can offer. And we do a good job of that. So we have heart catheterization, we can do stenting, not just in the coronary arteries, but in the legs and arms and other, neck areas that could need stents. We have artificial heart valves called TAVR, which is the transarterial valve replacement that was, I think, chatted about in one of our previous sessions by Dr. Cardone and Dr. Finley, which is a great opportunity for patients that don't want or are not in the best condition to have their chest opened to open heart surgery. We also offer state-of-the-art EP procedures. We do conduction system pacing here. We do defibrillators. We do left atrial appendage exclusion devices, which is a mouthful. It's also known as the Watchman procedure, which has some overlap for atrial fibrillation, preventing heart clots from forming in most hearts. So in a nutshell, I guess what I would say is that we offer a lot of procedures for most cardiac patients. Where we refer out would be for something called an LVAD, or a left ventricular assist device, or a heart transplant. Those would go to some of the surrounding academic institutions that perform those procedures that we do not.
Thank you, Dr. Schatz.
Absolutely.
Dr. Lorvidaya, we have some questions out there about implants, and specifically a question about, I'm going to see if I can say this correctly, implantable cardioverter defibrillator. So devices like this, for patients who need them, Once they have these devices implanted, how does their health and their life change? Can you tell us a little bit about the difference that you see in your patients?
Um, so I often tell my patients that the main goal of treatment with whatever we're using, whether it be medication, ablation, or devices, is actually to allow them to lead as normal of a life as possible. So, the purpose of doing these types of procedures are not to actually limit them from being able to do what they would like to do, that they enjoy doing. Um, uh, Specifically for the ICDs or the implantable cardioverter defibrillator, there are largely two types of them. One is called basically, just ICDs, and those are akin to having an airbag in a car, where it's prevent if your car crashes, the airbag deploys and it saves your life, and that's what the ICD is for. On the other hand, these types of ICDs don't actually make the heart any stronger or better. It's primarily just a backup kind of devices. There's a different type of defibrillator or different type of ICD called a biventricular ICDs, and those are more specialized where in certain types of patients, we can put this in, and not only that it would function as a regular defibrillator, but it also has an added function of um, kind of like a booster or turbo engine for the car. So it will actually help make the heart pump better and stronger over time. So in that kind of those types of patients, not only that they would have the backup mechanism when they were to have a cardiac arrest, but they also hopefully would have a much better quality of life, feel better, and be able to do more afterwards.
Great. Thank you, Dr. Lorvadaya. That's very hopeful information for our community to hear that these procedures can have a very positive effect on their outcome after the procedure. We do have a question about POTS. And in our previous Ask the Expert events focused on cardiology, we've had a couple questions. So I'm glad to see more of those coming in tonight. So Dr. Lorvadaya, there's a question about research or new insights on the increase of POTS. If there's any insights on controlling it and things we can do to prevent those issues or related comorbidities. I know there's kind of a lot of thoughts swirling around there, but do you have some initial thoughts that you can share with our audience?
Yes, POTS is it's an extremely complicated issue. It's unfortunately quite common, and there are a number of different types, and the types of patients who get them are also like, very variable. Most recently, the ones that have been getting a lot most attention are the post-COVID POTS. Basically, most patients who have so-called long COVID, have a type of POTS. And POTS, by definition, is simply that the patient's heart rate upon standing goes up over 30 beats a minute. And usually they also, most of their symptoms are related to changes of position from, lying down to sitting up to standing up. Um, to this day, there's actually not a single mechanism that can explain POTS in all the patients that we see. The prevailing mechanism that most people think about is related to pooling of the blood to the bottom part of the body, triggering a mechanism as if we are dehydrated or we're losing blood from the bottom part of the body. So basically, the heart gets that signal and then starts to pump faster to try to keep up with the lack of blood that's coming back to the heart because of the pooling. But there are many other different types of mechanism to explain that as well. I mean, most recently with COVID, because basically the main treatment for POTS is to make sure that patients stay well hydrated, and then also they eat a higher amount of salt than usual, but also that they stay physically active, and so exercise has been the mainstay for POTS. Unfortunately, there's new data for POTS in the long COVID patients that show that exercise can actually be very harmful to patients with long COVID for POTS, because they can actually have lots of muscle cell damage from that. So there's a lot more research that has to be done in that arena.
Great, that's awesome information. Thank you, Dr. Lorvadaya. Dr. Schatz, we have somebody who's drawing upon, again, some comments that you made earlier in tonight's program about diastolic dysfunction, and if diet and exercise can help somebody improve that condition. What has your experience been like in treating patients?
I think the short answer is that diet and exercise most of the time, and I would have said all of the time until Dr. Lorvadaya just spoke, is a good thing. For the most part, in the majority of people, eating a healthy lifestyle, living a healthy lifestyle is beneficial. Particularly with diastolic heart failure, there's been really, really good breakthroughs in the past 5 to 10 years in medical therapy. Up when I was training in residency, there wasn't an approved medication that was available in the guidelines to treat diastolic heart failure. Now we have really 2 strong evidence-based medicines and a couple with a little bit weaker evidence that are used, and patients have really good outcomes on these medications. When it comes to diet and exercise, I think the benefit that a lot of patients will get is what we see in the phenotype of patients that have diastolic heart failure is usually high blood pressure, obstructive sleep apnea, and obesity. And all 3 of those things benefit from a healthier lifestyle. So if you decrease the nidus for the issue, which would be those things that I mentioned, then most patients will do better from their symptomatology.
Thank you so much, Dr. Schatz. We have so many great questions, and you guys as a panel are just amazing tonight. So thank you for your engagement all around and providing this great information to our community. We have a few people in our audience who are wondering, if conditions like tachycardia and AFib are inherited. And I feel like each of you on our panel probably have some details and expertise behind that. So Dr. Schatz, let's start with you. Do you see patients who have tachycardia or AFib in their family history?
I think that the answer here is that yes, we do. We do see patients that come into the office in a younger age and have episodes of AFib, and maybe like Dr. Lorvadaya was mentioning earlier, they would have 1 or 2 episodes a year, and the same thing happened to their parents when they were a similar age. I think the other part of the question is, do we wholly understand how we can alter people's risk factors if they're otherwise healthy? I think that part is yet to be discovered. I do think there are certain genetic diseases that predisposition people to atrial fibrillation, and those would be people that have like heart valve issues like mitral valve prolapse and mitral regurgitation. And that's really kind of mechanistically due to the stretching of the top chambers of the heart and the enlargement of the atria that lead to the atrial fibrillation. But I think there's probably a whole host of answers, and Ariel and Dr. Lorvadaya probably have something to add here.
Thank you. Dr. Lorvadaya, go ahead.
Yes, there's certainly a genetic component to many arrhythmias for sure. And like Dr. Chat said, the kind of how we sort that out is extremely complex. We naively thought that with the Human Genome Project that we'll be able to isolate the mutation that causes AFib or heart attacks and so on and so forth. But it turns out that not every family has the same mutation. So there are thousands of different types of mutations that cause, similar types of diseases. So they may run in the family, but we don't really have a good way to track them by way of doing genetic testing. So right now we're pretty much limited to, treating, the problems when they come up. And as a side note, um, we estimate that about 37% of the population over 65 have AFib. So that's, nearly 40% or, 4 in 10 people. So if you think about, any family out there, if they have, 10 family members, 4 of them, have AFib, whether it's because of genetics or because of the statistics as well.
Thanks, Dr. Larvadaya. And Ariel, do you have any comments you'd like to add?
I would just no, very good discussion from Dr. Schatz and Dr. Lorvadaya. I would just say, there are diseases that have a strong, genetic correlation, and so we, really, I think that's also a part of, every visit as you try to, clue into someone's family history, and sometimes it does affect the decision making and how you proceed with evaluations. AFib, I would say, it's good to know, but if we suspect you have AFib, we're going to look for it the same way. It doesn't change necessarily that you've had a family member who's had it, whereas there are other conditions that we do. If you've had if you have a family member with coronary disease at an early age, then we're a lot more aggressive about risk assessing your risk and looking for coronary disease. So
Thank you, Ariel. Well, we are coming up to the top of our time for this evening, but I think we have time for just a couple more questions. Ariel, there's a question out here for you specifically about diet and nutrition and what kind of a role that plays versus medication for general cardiac health. In your experience, does diet or exercise help mitigate the need for medication? Do you still recommend medications? Tell us a little bit about your experience.
So I have to say that, it's kind of a mixed bag and that diet is always important. So, gut health and healthy gut biomes is important for, all number of processes, and cardiovascular health is no different than that. Some people need medications for different reasons. And so we have people on medication for heart failure or heart disease, or, they have an arrhythmia that we're treating or trying to prevent. And so there is definitely a place for medications, but the goal is, always to try to get people on the least amount of medications. And that's really where diet can play, a significant role. And I use high blood pressure as an example, and cholesterol medication. And, I often will say in the office, you're not quite at target. If you're really high, we have to add medications, but if you're kind of on the borderline, I will offer suggestions for lifestyle changes and say, well, if you can make these changes, then we may not have to add medication, or maybe we can back off on medication. And so I think diet, lifestyle is very important in the whole decision making as far as medications go, but sometimes you still need them.
Thank you so much. We have one final question that we can cover from our chat this evening. And Dr. Schatz, this is for you. So we've seen news headlines and we have some questions here related to those about cardiac care linked to COVID. So there are some people who have had COVID and then have cardiac issues later. We have folks who have said, I've gotten a COVID vaccine and now I have cardiac issues. So for folks who aren't really sure what to make of this, if the COVID is related or not related to their cardiac issues, what resources might you recommend for someone to read and learn more? And also, what kind of conversations should they be having with their doctor about these issues?
Yeah, thanks, Emily. It's a really, really good question. I think I want to start off by saying that, before a little over 3 years ago, this virus did not exist. So a lot of the frustration and the concern around COVID-19 is the fact that we're all learning about it as we live. And so this is not dissimilar to tuberculosis from decades ago, and how we now know so much about it. We'll continue to know more as time goes. As far as whether or not your COVID-19 shot or COVID itself caused a heart issue, the temporal relation that we know, exists between, let's say, myocarditis after COVID infection. We know that usually happens during the acute infection phase. So if you have symptoms of myocarditis concerning heart muscle injury, and we get an echocardiogram that looks concerning, follow up with a cardiac MRI, then we could say, temporally speaking, it looks like your virus, which COVID-19 is not the only virus and not even close to the most common virus to cause myocarditis, but the incidence is far less than 0.5% and closer to 0.1% of people that get COVID-19 have myocarditis. In fact, the 99% of people, that small 0.1% that get myocarditis, it's self-limiting and they recover on their own. Very few patients with the myocarditis do not do well. So it's a very complex question, and we're always happy to discuss these things with our patients and in their individual office visits. As a whole, we know that it's not good to get the virus. Getting less of the virus is better, and overall health before you get the virus is usually important in how well you do contracting the virus and beating it.
Very well put, Dr. Schatz. Thank you.
Thanks.
We do have, I think, time for just one last question. So, Ariel, I'm going to send this to you. We have some folks wondering if there are certain supplements that can help them with their cardiac health. Is that something that you see a lot in your practices, or anything that you typically recommend to your patients?
I don't, a lot of people are on a lot of, various supplements and have done a lot of research on that. I don't typically make a preference for a particular supplement. I recommend good food. And so my, typical recommendation is to look at your diet and, really focus on, anti-inflammatory foods, avoiding highly processed foods, the foods that we know are atherogenic. And I really try to focus a lot more on specific diet recommendations and health versus supplements.
Yeah, Emily, I'll add to that as well, and I'll echo what Ariel said. I mean, some of the nicest part about anything is having a magic bullet, or something that we can use in order to make something better. And it'd be nice if it was just a little pill that had a little bit of something green in it that would make your disease process better. But ultimately, we maintenance our vehicle engines every year with an inspection. We get oil changes usually twice a year. We take really good care of our cars, and those are replaceable. And we can go to the shop and buy a new part for a car. The bad thing is, for most people, the body you get is all you get, and not a lot of people get a chance at a second part or another organ. So you have to really take care of it, and you have to treat it better than you treat your car, and you have to go to the doctor, which is in this case the mechanic in the analogy, and really continue to care for yourself throughout your lifestyle and all time. And there isn't really any good data that I'm aware of for supplements for a lot of disease processes, unless you are short on that supplement. And a lot of that is usually tied into diet. And sometimes people with certain GI illnesses have trouble absorbing certain things and have to supplement that way. But most of the time, for instance, vitamin C, that's something that if you take enough in your diet, that you actually excrete in your urine every day. So taking pills isn't going to help you store it.
Well, I think that's a great way to end our program for tonight. Fantastic comments from everyone on the questions from our community. I hope that the folks who are watching have come away with some good information to help live long, healthy lives with the one car that they have that they're driving around in their own body. I want to say thank you to our panelists for sharing your time and expertise. And of course, a huge thank you goes to you, our very engaged viewers, for tuning in to Ask the Expert. If you have questions about cardiac care or want to learn more about our services, we invite you to visit our website for additional resources. You can find us online at heart.mwhc.com. And be sure to watch the Mary Washington Healthcare Facebook page and other social media channels to stay informed of the latest health and wellness information. Be sure to mark your calendar and tune in next month on Monday, February 26th at 7 p.m. to hear our experts discuss women's cardiac health. Again, many thanks for joining us this evening. Please stay safe and healthy and have a great night.